Good evening, everyone. Thank you very much for coming. For those of you still finding a seat, there's still seats available. It's great to see so many people here. My name is Joan Batorf. I'm a faculty member in the School of Nursing at the University of British Columbia, Okanagan campus here in Kelowna, and director of the Institute for Healthy Living and Chronic Disease Prevention. This event tonight is part of our Embrace Aging Month, and I know some people have been to some of our other events, and there's more yet to come this month. Embrace Aging is an initiative that we've launched. This is the third annual Embrace Aging series that we're doing in conjunction with Interior Health. And we wanted to celebrate and raise awareness about positive aging. So once again, we have a number of events. There's actually 14 this year throughout the Okanagan Valley. You can, there's a handout of those events if you would like one, and of course they're on our website. The sessions are designed for everyone, so it's great to see both young and older adults here tonight. This is the way with most of our sessions. They focus on a variety of topics, and tonight it's atrial fibrillation. And our goal in all these events is to inspire us all to live a healthy and positive life. So with that, I'm going to introduce Chris Walker, CBC host, who we're delighted to have as our moderator tonight.
Thank you very much. Thank you, Joan. Hello, everybody. So my job is really to stay out of the way and let the panelists do their thing, but I do want to just tell you a little bit about how these events work. This is my third or fourth, and they're always great. I always learn so much as you are about to, as we all are about to. So a little bit of an introduction to atrial fibrillation. We're going to get more into this, obviously, in a moment. But it's the most common kind of irregular heart rhythm. 350,000 Canadians have AFib, and it's increasing because the population average age is increasing. And there may be other reasons why it's increasing too. Yes, people are nodding. Good. So we'll hear about that a little bit as well. It's a progressive chronic condition that can get worse without treatment, but can be managed through, maybe not surprisingly, diet and exercise and healthy lifestyles. It is one of the most common causes of stroke, which I didn't know. And actually, it's what Richard Nixon died of. I just learned that today. Healthcare professionals and researchers are focused on better finding ways to better manage atrial fibrillation. And we'll talk about tonight we'll talk about the problems and some of the challenges in addressing AFib if you've been recently diagnosed. So each of our guests, which I'll introduce in a moment here, will speak for 10 minutes about AFib. They all have a particular expertise in the area, whether it's diagnosis or treatment or lifestyle. We'll take a short break after that for some refreshments, which are behind you on the table there. And we'll reconvene for a discussion where you can ask questions of our panel. And that's always really interesting. We're going to try to keep it to a tight timeline. We'll hopefully have this all done by 7 so we can get everybody back to real life. Now, we also have evaluation forms on the desks. This is where you mark down how handsome your moderator was and how helpful our panelists are. We'll be taking a few pictures tonight. If you do not want to be included in the pictures, just please let us know before you leave. And with that, let me introduce our panel. I'll introduce them. I'm not sure if they're seated in the order they're speaking, but we'll soon find out. Dr. Frank Halperin was a general cardiologist in Toronto before he moved to Kelowna in 2004. He's been involved here in a wide range of clinical and research activities with a particular interest in atrial fibrillation. He's developed and directed the Atrial Fibrillation Clinic at KGH and conducts research on the topic. He's also currently serving as the medical director for cardiology at KGH and Interior Health, Dr. Frank Halperin. Dr. Kathy Rush is an associate professor and graduate program coordinator in the School of Nursing at UBC here in Kelowna. She's leading research on ways to support people with atrial fibrillation, whether they live in rural communities and need better access to specialty services or are dealing with issues in just living daily with atrial fibrillation, Dr. Kathy Rush. Ann Pistawka. Ann Pistawka is a physical therapist working at the Central Okanagan Association for Cardiac Health. Now, you may hear the acronym a few times tonight. The acronym is very helpfully COACH. So it's a cardiac rehabilitation program. She's the health educator and exercise specialist. For 15 years, she's worked with patients with a variety of heart conditions, including atrial fibrillation. She helps support active and healthy lifestyle changes. She teaches stretch and strength sessions in a yoga style at the Kelowna Cardiac Exercise Society program. Ann Pistawka, welcome. And last but not least, Dr. Gerry Morrison is a Kelowna-born resident and alumni of UBC. He practiced dentistry in Prince George and following graduate school in Washington, practiced as a specialist in periodontics in Kelowna for many years. He's now retired. He remains very active in sports as a competitive master athlete, and we'll hear more about that. Sometimes a blessing and a curse, Gerry, am I right? He cross-country skis and is a cyclist. He has been diagnosed with atrial fibrillation, and so he's here to provide the real-life side of all of this. Please welcome Gerry Morrison. So with that, I will turn the mic over to Dr. Frank Halperin to introduce the topic to us.
How do I spell it? I spell it. Not the way it was framed.
Easy questions first.
Yeah. So Halperin. And by the way, can everybody hear me? Gotta go much more. Okay, now I'm like a rock star. Okay. Anyhow, welcome everybody. I'm so happy to see you all here. It's really, I'm actually not surprised at all that we have a large group of people here, because atrial fibrillation is something that touches most everybody's lives. It's a very common arrhythmia, something that we see a lot of, and given those issues, I'm happy that you guys are all here. I get the privilege of doing the lead off, and what I'm going to do is, before I talk about atrial fib, I'm going to talk a little bit about the heart and how the heart functions, because it's really quite an incredible organ. In some ways, it's unbelievably simple. It's simply a bag that squeezes with a couple of check valves, and with this, the blood goes around and around. And as I'm sure you all know, as the blood comes back to the heart, it has to collect somewhere, and it collects in a chamber called the atrium. The atrium does more than just simply collect the blood. Once it has the blood within it, it primes the ventricle, which is the major pumping chamber of the heart, and that results in a nice, efficient way for blood to go around and around. Like every mechanical system, or most mechanical systems, the heart is controlled by an electrical system. And the way that the electrical system is organized, there's a group of cells called the sinus node, and these cells act as a cardiac pacemaker. So what happens is the sinus node fires, so the cells fire and create a little electrical impulse. It goes to the atria, which then contract, squeeze the blood down into the ventricles, and then the electricity then will travel down to the ventricles and cause the ventricles to contract, and that causes a nice, orderly, and efficient mechanism. And so just kind of like a clock would work, sort of like a tick-tock, but when we're talking about the heart, it's more of a lub-dub, okay? So the heart this goes around and around, and the electrical system is what controls it. This is how sort of the normal issue, how things work normally, but in atrial fibrillation, things are anything but normal. So what happens in atrial fibrillation is that upper chamber, we lose the sinus node, or the normal sinus rhythm, and there's total chaotic activity of electricity up there. So it's all like little sparkles going all off in the atrium. And instead of having nice, organized activity, we have chaos going on. The atrium beat very fast, and actually, if you looked at the heart, it would look like the heart was like a little bag of worms squealing, okay? Since the top beats very fast, that's what drives the bottom. The bottom chamber of the heart beats quickly as well, and as a result, the ventricles will beat very quickly. We lose the typical coordination and efficiency that one would have in normal beating, and as a result of this, the normal heart activities don't work as well as they should. And if you think about it, the heart has a few jobs to do. One of it is to pump blood around the body, and so that's to make cardiac output, which gives us the energy that we have to do the activities that we normally would like. Its also job is to create blood pressure, which keeps us from getting dizzy and lightheaded. And the other job it has is to clear the lungs of excess fluid, so prevent congestion in the lungs. So when we have atrial fibrillation, those activities, they get kind of interfered with, and as a result, we start to see problems in each of those fields. So from the forward flow, if you would, people can tend to get tired, fatigued, they can get dizzy and lightheaded. And from the backward flow, the congestion in their lungs, they can get short of breath. So people who have atrial fibrillation will often have these types of symptoms. Not always, but often. The other issue we have, so that's how people get symptoms in the atrial fibrillation, but there's also another more sort of pressing issue, is that we have some concerns about that atrium just sitting there fibrillating. And we already heard a little bit about stroke, and this is where the stroke business comes in. So what happens with blood? Blood is sort of, has the properties of it. When the blood is flowing, it stays in a nice liquid state, and that's the way we like it. If we're involved in trauma or got cuts or whatever, the blood will stop moving. The blood at that point is designed to clot, okay? Stop, and that's a really handy thing to happen when those things occur. But it's not a good thing to happen if it happens within the blood vessels, and particularly not within the heart. So what happens is when the atrium are fibrillating, the blood's not moving, it gets stasis and pools, and little clots can form inside the heart. If they would just stay there, that would be fine, but they have a tendency not to do that. And what they can do is little clots can break off, and they can travel with the bloodstream. And since we know that over 20% of the blood coming out from the heart goes up to the brain, if that clot should go up to the brain, it can cause a major issue, and the real issue that we see is stroke. So when we talk about atrial fibrillation, you might say, okay, that's an interesting thing. Okay, I've heard a little bit about it, can make you short of breath and whatever, perhaps have a stroke. But why should I particularly care about it? Why for you guys? And I imagine since you're here, you probably have more issues than the average person on the street. But if you just look at the four of us here, I'm interested in it because I know that my chance of having atrial fibrillation in my life is 1 chance in 4. So the way I look at it here, I'm actually in a pretty good shape because I'm thanking Gerry there for taking one for the team. So I'm feeling pretty good. I think Anne and Kathy feel pretty good as well. Not so sure about you guys. You're going to have to sort it out amongst yourself. But really, so everybody in the room has a 1 chance in 4, 1 chance in 4 risk of developing atrial fibrillation in their lifetime. And the issue with this is once that has occurred, we start, the next number that we worry about is the number. So we go 4, 5, 6 of these numbers are really easy to remember. So 1 in 4 chance, that increases your chance of having a stroke by 5 times over your baseline risk. So it's a big issue, okay? And that's why we're here, and that's why we're talking about things. The number 6 number is, if you hear someone having a stroke, we heard about Richard Nixon, 1 out of every 6 strokes is the result of atrial fibrillation. Often it's atrial fibrillation that the person never even knew about it. This is their first presentation. And so this is why it's so important. And the one nasty thing about strokes from atrial fibrillation, since these clots tend to occur in the atrium, which is really a big chamber, the clots tend to be big. Big clots can result in big strokes. So these are the ones often that result in big problems. So they're not just it's a little thing, goes away. These often can be devastating, life-changing strokes. So this is really a major issue for us. So this isn't just, so for some of you who may be students or whatever, and you say this is something interesting to learn about, it's something important in each and every one of our lives. And I'm certain that most of us have at least 4 family members, 4 friends, whatever. So this is something that's likely going to touch all of us during the course of our lives. So that's the atrial fibrillation. That's what it is. That's why it's important. I'm not going to talk an awful lot about treatment because I'm going to let the others here talk a little bit about things, but I am going to start just kind of introduce the topic of treatment. One of my major jobs and why we created the Atrial Fibrillation Clinic was to improve the treatment for atrial fibrillation for people all around here. There's really 2 parts of the treatment of atrial fib. One of the things I talked about already was the loss of efficiency, and that issue is important because there's really thing in medicine, everything comes down to 2 things. It comes down to how do you feel and what problems is it going to cause for you in the future. And since atrial fibrillation, as you've heard already, it's not just something that you get, it's something that you have. and it's something that you live through, is something you're going to end up living through for most of your life, okay? And it's sort of more of a journey type of issue rather than something you get, you treat, you cure. It's something you go through a long time. So what we try to do is we want to make sure that people feel well with this. So what we try to do is to make sure that people have a treatment that will help them feel better. So usually that means taking that fast, rapid rate, slowing it down, either by putting them back into normal rhythm or by simply controlling the rate. But much, much more important, and this doesn't get nearly the emphasis that it should, the biggest goal of treatment in atrial fibrillation is stroke prevention, okay? Because again, sure, we have some treatments if you have a stroke. It's really important that you go to hospital quickly because we can give clot dissolving agents and things, and they can be miraculous if they're done quickly, but much, much better than having one of those is to prevent having a stroke. So if you have atrial fibrillation, the most important thing is to get assessed for what is my stroke risk, and if appropriate, the treatment we should really think about is the type of anticoagulant or blood thinners is the sort of the term on the sort of slang term that's used, and that these agents are incredibly effective at reducing your likelihood of having stroke. So what we like to do is, two major goals when we see people, we want them to feel better, and we want to cut their risk of having a stroke down. And really that often means medications and medications long term. Having said that, there's a lot of things you can do outside of medications. That's where Anne can come in. Kathy will talk about some of her research and some of the other things that we're doing here. So with that, I think I've exhausted my 10 minutes, and I'll leave it there and pass it over to Kathy.
So after that eloquent description of atrial fibrillation, I get to talk about just feeling better in some sense, but I'm going to talk about stress. We all are very familiar with stress and have dealt with it in various ways over our lifetimes. It's a big issue with patients with atrial fibrillation. Certainly in the research that we've been doing, patients tell us regularly, and the clinicians here would certainly attest to this as well, that stress is a big deal for patients with AFib. So what do we know about atrial fibrillation? We know that at the current time that stress doesn't really cause atrial fibrillation, but there certainly has been recent research that indicates that there is an association between stress and atrial fibrillation. So some researchers down in the southeastern United States, they surveyed people and had them respond to questions about the extent to which they felt that they were unable to control important events in their lives, or the extent to which they felt burdened by what they needed to do, or just found it difficult to deal with situations. And they found that patients who scored really high on that self-perceived stress also had an increased incidence of atrial fibrillation. And that was regardless of what the person's age was, what the sex was, what the education was, what the race was, and even what the income was. So certainly we are seeing, it's a small sample, but nevertheless seeing some relationship certainly between perceived stress, which many people tell us they have, and atrial fibrillation. We also know that there is some association between negative emotions and atrial fibrillation. Again, some researchers, they had patients keep electronic diaries of their emotions over an entire year. And during that period of time, patients were also monitored. Their heart rate and rhythm was monitored to see if they were going in and out of rhythm. And they found that anger, stress, and sadness and anxiety, as patients experienced those, there was an increased incidence of their atrial fibrillation episodes. So again, anger, anxiety, stress, and sadness were those four emotions that seemed to contribute to increased AF episodes. They also found that those episodes, so when patients, they develop those episodes immediately after experiencing some of those negative emotions, or they could, if they had a particularly bad day and a day of lots of negative emotions, the very next day they could actually develop episodes of atrial fibrillation. So certainly negative emotions can contribute to some AF episodes, but the good news is that patients who had positive emotions and happiness had decreased episodes of atrial fibrillation. And one other area that I just wanted to mention was, as well, is that certainly some of our traits can contribute to atrial fibrillation as well. So there's been some small bit of evidence just showing that patients who tend to respond very emotionally to situations can certainly develop atrial fibrillation. So the more reactive you are to situations in your lives, probably the more tendency there is for an AFib episode. But I wanted to just share with you also some of the research that we've been doing that's tried to contribute to an understanding of stress. We wanted to look at what kinds of stressors and what kinds of coping strategies do patients with AF, what do they use? And so we were interested in looking at patients who were having an electrocardioversion, which is really an application of an electrical stimulus to the heart to actually try to restore the heart to normal rhythm. Frank said there are several treatments for atrial fibrillation, and that's one of them, one that can restore the person to normal sinus rhythm. And so we were interested in looking at the stressors and the coping strategies of patients before and after this particular procedure. And so we interviewed patients before and after, twice after, at 6 and 12 weeks, just because we were interested in that time frame as a period when people might relapse into an abnormal rhythm. And so we found before the procedure that patients, of course, spoke about a lot of stressors. Of course, the symptoms were a huge stressor for patients. Patients also talked about just healthcare demands and just treatments as being a stressor. Just the numbers of appointments, coordinating appointments, and trying to and seeing a number of providers was also stressful. But they also spoke a lot about non-atrial fibrillation stressors. So if they were caregivers, if they were a primary caregiver, if there were some financial stressors, if they were still working, all of those were stressors that they dealt with. But they had a large range of coping strategies, and so they tended to deal either with kind of the emotion related to the stressor, or they tried to problem solve the stressor. So there were a variety of things that they used. So in some instances, they reframed the problem. So sometimes they simply thought about their stressor more positively. They tried to think about it in the present, and they tried not to escalate into the future. Many patients engaged in relaxation techniques. So they rested and they engaged in like deep breathing exercises, or they engaged in really low-level activities like painting or slow walking. Others also, like they dealt with their stressors by trying to understand the stressor. They wanted to know about it so that they could try to prevent it in the future and deal with it accordingly. Many patients also were coped with their stressors by seeking information, and so they sought information to try to understand oftentimes the treatments, some of the risks and benefits of their treatments. And then others really spoke about monitoring their bodies. And so because it happens that those symptoms are experienced in the body, patients talked about just having to sort of balance their activity with their symptoms. And then many of them came to almost an acceptance of the condition, where they sort of realized that indeed there were aspects of it over which they had no control, and that really stress wasn't really very productive to their condition. So we found that certainly before the procedure, patients had lots of stressors. They brought into play a number of coping strategies, but then after the procedure, and many of them were successful, had a successful cardioversion, so they were restored to normal rhythm. In fact, their stressors decreased, so they no longer had those symptoms to deal with, but they still continued to have a lot of non-atrial fibrillation stressors. So they still had the caregiving, they still had the work stress and other such stressors that they were dealing with, and yet they didn't maintain their coping strategies. They tended to decrease their coping strategies. And so we were just concerned about that trend because we felt it was important for patients, even after the procedure, right, to continue to employ some proactive coping strategies in order to prevent some relapse. So the particular strategies that patients use were certainly have not been tested per se, and there actually has been very little in the way of testing interventions, stress reduction interventions with patients with atrial fibrillation, unfortunately. There has been, Anne's going to talk about yoga as one sort of activity that has shown some tendency to help with AFib. There have certainly been, there are other kinds of there's research going on just in terms of meditation and mindfulness activities that people are exploring to see if in fact they can help in stress reduction, and then there are other techniques, even patients being able to learn more about what is it that how do I respond to situations, what am I thinking, what am I doing, what are my emotions, and trying to understand those, and having people help you understand those so that you can actually try to address stressors in your life. So there's much more that needs to be done in this particular area of stress. There's been much more in the last few years, but it's a really understudied area, and we certainly hope that as a team that we can continue to help to understand more about it and help patients with managing their stress.
Thanks, Kathy, and welcome everybody. I'm really pleased to be able to talk to you a little bit about extending on from Kathy's conversation about stress and really self-managing too. And you're hearing that also from Dr. Halperin, how this is a condition that is a chronic condition and that people are learning how to self-manage that. And so learning what to do in your own lifestyle and changing really becomes a topic of conversation. So what you've heard also from Dr. Halperin, that one of the most important things is to have atrial fibrillation identified and then your stroke risk assessed and any treatment started from that. But once that's done, it's really about minimizing your symptoms and the severity of the symptoms and managing, as I said, through the years to come. So some of the more really exciting research that's been done lately has shown that some of the things you can do yourself can really have a big impact on that. And one of the Australian groups has done a study in looking at those with atrial fibrillation, and they have shown that those people that have had about a 10% weight loss can actually have a huge impact on the severity, duration, and number of episodes of atrial fibrillation that they're having. Their quality of lives improve. As well, they've also measured inside the atrium where that fibrillation starts, and they've shown with some of the weight loss that actually can change for the better what's happening inside the atrium. There's some remodeling there. So that's really exciting news that by losing weight, this program that they were on also included exercise. And when they looked at the exercise portion, they noticed that people that improved their exercise capacity as well as having that weight loss, really, there was a cumulative effect where it was even a much, much greater effect on their symptoms and on their atrial fibrillation. So I think that shows us that, there are things that you can do. When we think about exercise, we think about, well, how much? What kind of exercise? The exercise that they were doing in this group and the exercise that we advocate in our coach program is really that aerobic exercise, moderate to vigorous, where you're getting your breath up a little bit, but you're able to sustain it. And it's important that you can sustain it and get the big muscles working in a rhythm and your heart rate's up to that moderate part where you can still talk. That's kind of the zone that seems to have the greatest benefit. And for a minimum of about 3 days a week, but the more days a week, the better. And other activities that they've done research on and looked at is doing the high interval training you might have read about, and that's where people go for bursts of activity. That's just in the early stages of research, and there's been some research to say that can be beneficial as well. And also another type of exercise that Kathy mentioned is yoga. So they've done a few studies on looking at participating in yoga a couple of times a week with a meditation component, the breathing, can all help to sort of settle things down where the quality of lives improve. It may not take away the atrial fibrillation, but improves the severity, duration of some of these episodes. As well, another nice factor is it brings down blood pressure, brings down heart rate. And of course, atrial fibrillation is where the heart rate is raised a little bit higher, and the treatments are aimed at lowering that. So some of these benefits from this type of exercise might be a really good thing. There are incidences where, exercise is like medicine, and having none of it has no effect, but having too much of it can have a detrimental effect as well. So there are some cases with atrial fibrillation where they've shown that in some individuals that are mostly competitive, elite, very long distance endurance athletes, they actually have a little bit higher incidence of atrial fibrillation. And I think Gerry might be speaking to that a little bit. And that you'd think that would be doing any exercise is a good thing, but with these long endurance type of activity where their heart's under a lot of stress for many, many hours, over the years that might have a remodeling effect on that atrium and cause issues down the line. So we're just learning about that. That effect seems to be in men. It hasn't been shown in women to be the same, and I think we'll learn more and more about that as time goes on. But those folks have to learn how to manage their symptoms and the stroke risk and all that as well. So there seems to be this kind of a sweet spot for exercise. No exercise is not great. Too much is not great, but somewhere in the middle, and that seems to lay between 3 and 5 days or 3 and 7 days a week, almost every day, but a moderate amount, 30, 60 minutes a day. And anything beyond where you're doing long distance things may not be the best thing for a heart that's in atrial fibrillation. Some of the other things to think about when you're self-managing atrial fibrillation are sometimes there's triggers for episodes. So some people might have atrial fibrillation constantly, and some people may have just episodes of atrial fibrillation. For those folks, there may be triggers in their lifestyle that kind of bring that on. Some of those things that have been identified are things like caffeine, alcohol, cold drinks can sometimes bring that on, or sometimes exercising really quickly without a good warm-up and raising up that heart rate really fast could be a trigger. So, and if everyone's an individual, so you really just have to analyze for yourself, make a mental contact with what is maybe triggering some of these episodes. Take some of these things out of your regular lifestyle and maybe bring them back slowly to see whether it's something that you would have to keep from using your like caffeine and alcohol, those sorts of things. And certainly there's lots of people where that might not have any effect, but it's important to analyze those things. So there is lots of research that's looking at exercise and lifestyle and diet to help control, but I really will just leave saying that losing weight is one of the biggest things for those individuals that are overweight. That can really, really help you. And 10% of weight loss is really quite modest. And as long as that's sustained over the long term, it may have a huge influence for you, as well as increasing your exercise. That aerobic walking comes to mind as kind of the best one. And you can get into that nice range with a walk or biking or anything where you get that heart rate up. And then also making sure that you have that stroke risk at least assessed by a healthcare professional. And if you do have to go on, sometimes people are put on blood thinners for that. And if you're on blood thinners, there's another thing to think about with your exercise and lifestyle is just to be aware that, you want to take extra caution wearing a helmet if you're going on a bike ride, and really things that are pretty common sense. But if you have a bump or a fall, it may be a little bit more of a problem for you if you're on blood thinners because of bleeding risk. So you just want to be more cautious about those sorts of things in returning to your activities. And now I'm just going to finish off with that and pass you over to Gerry.
Thank you. I'm going to take a different approach than all these. Of course, I've had this, and I've had it for 7 years, and it's really affected me, my life, over the past 7 years. So I've been given 10 minutes by Joan, strict 10 minutes, to give you a summary of from start to finish of what I've gone through over the last 7 years. It's called A Patient Perspective, Atrial Fibrillation. I'm going to read it to you because there's a lot to go through. It was 5 minutes after the start of a cross-country ski race at Sovereign Lake on March 7th, 2009, that I became first symptomatic. The previous week, I had completed a cross-country ski race in Rossland, having what I thought was a good race. During the week, I had developed a mild cold, felt a bit sluggish, and noted a little more difficulty climbing hills on the skis, but just attributed it to the cold. By race day, I thought I was better and ready to go. Less than 2 kilometers into the event, I developed severe shortness of breath, like nothing I had ever experienced before. I stopped and let everyone pass me by, then slowly skied to the finish after about 7 kilometers. That was the start of my 7-year journey with AFib. As Dr. Halperin says, it was a journey. It is a journey. I still kept skiing at an easy pace with my friends for the rest of the season, and only noticed mild shortness of breath on climbs. I thought nothing of it, just needed more time to recover from a cold. I did not wear a heart rate monitor at the time, but was aware of an erratic rapid pulse, which I thought a result of my past respiratory infection. Cycling season began. One ride Easter Friday with a good friend of mine whom I had ridden with on several trips in Europe, I found I was very short of breath on any extended climb and got dropped. I thought my cycling fitness was lacking, even though this had never occurred before and I had been cross-country skiing all season. As time went on, it became evident to me, myself, and all my friends I was really struggling on the bike. I did not feel well. I was always tired and lethargic, sleeping much more than usual. A 2-hour ride felt more like a 4-hour ride. Finally, one day, my friend said to me, "Something is physically wrong with you." Late May, and 10 weeks after my first episode, I saw my GP, had an ECG, and was diagnosed with persistent atrial flutter. I was put on Coumadin for 6 weeks, then had my first cardioversion in July 2009. Dr. Halperin was there. After I thought my problems were gone. For the first 3 days, they were. I could not believe how freely I could breathe and climb hills without getting leg pain. 4 days later, I went back into atrial flutter, but still felt better. I was referred to outpatient cardiology at KGH in August 2009. It was suggested I try antiarrhythmics for 8 weeks, then have another cardioversion to see if that would stick. I suggested referral to an EP specialist for possible ablation. He asked me, "How did you know about ablations?" as he had never mentioned them to me as an option. I said our son had been referred to Dr. Leather in Victoria in 1999 for EP evaluation of an arrhythmia while at UBC. And while waiting for him, I read the brochure they gave to patients and thought that if I ever had the same, I would keep this in mind. The cardiologist agreed to refer me to Dr. Stearns from Victoria, who came to Kelowna periodically. I saw Dr. Stearns in September 2009. He agreed I would be a good candidate for ablation, as the success rate for first-time flutter ablation was 85%. The success rates given me 1 year following treatment for atrial fibrillation were about 25% for cardioversion, 50% for cardioversion coupled with antiarrhythmics, and about 60 to 70% for one ablation, increasing to 85% for successive ablations. The cardioversion was not successful for me. I tried antiarrhythmics without any success, except to make me feel worse. I was keen to have the ablation, which I did in November 2009. It was successful for 4 days. Then one day while cycling, my heart rate monitor told me I was back in AFib, a flutter. I was told this was not uncommon for the first few weeks, so just wait it out. I did with no change. After several months, Dr. Leather then suggested I go back on 2 antiarrhythmics for an 8-week period, then try another cardioversion. This was in April 2010. I was not optimistic it would stick. Amazingly, it did. I kept on the same drugs for another 6 months, then slowly weaned off them. I stayed in normal sinus rhythm and was able to resume competitive cycling and cross-country skiing at the same level as before. I felt great, no fatigue or lethargy, and no medication. February 27th, 2014, 5 a.m. in the morning, almost 4 years now without AFib. I could tell something was amiss. My heart rate monitor read 95/100 on a rising, when it was usually in the 42 to 44 range. The next day, I went to my GP, who referred me to cardiology. My heart rate went spontaneously back into normal sinus rhythm. I had entered a ski race that weekend in Kelowna, but during the warm-up, I knew things were not right. I started the race, but had to quit halfway through, as my heart rate was spiking at 225, and I was being passed by everyone who had never passed me before. That was probably the lowest point for me. I was to race on a relay team the next day, but found a replacement and instead went skiing elsewhere. It was one of the worst skis I'd ever had. I was really down mentally. I had trouble breathing, I was slow, fatigued, and my heart rate was all over the map. Next day, I saw my GP and went back on antiarrhythmics. I thought I was done. But surprisingly, after 36 hours, I went back into normal sinus rhythm. It did not last. 9 weeks later, I woke up one morning, back in a flutter. I was referred back to the cardiologist and EP with a decision made for a second ablation. This was done in June 2014. It was a much longer procedure than the first, approximately 6 hours. It took a bit longer to recover, but I was back on the bike within 4 days, going very easy. I did several races that summer while back on antiarrhythmics, but found they dropped my performance level by about 7 to 8% because my maximum heart rate was always 10 to 15 beats per minute below where it should have been. I had another relapse one November morning, went off medication, but was quickly seen at cardiology and given another cardioversion. I saw Dr. Leather the following January and told him I would really like to get off all the medication as it really compromised my ability to compete and made me fatigued. I was still in normal sinus rhythm, but opted to undergo a third elective ablation as he thought this would offer me the best chance to ditch the medications. Late March 2015, a year ago today, I had my third procedure. Not quite as long as the second, but still 4 hours. I was not prescribed any medication post-op except anticoagulants. Early April, about 3 weeks later, I was back on the bike trying to keep up with some of the young guns. That was a big mistake on my part. Near the end of a 3-hour ride, my heart rate monitor told me I was back in AFib. It remained high for about 12 hours despite dosing myself with medication once I got home. Back to cardiology in the AFib clinic. Was told if it did not convert on its own within 2 days, I would need another cardioversion, which I had in late April and back on medication again. I took it very easy on the bike that summer, but crashed on my time trial bike and broke my collarbone. So no bike for the month of July. But finally, I thought I would give my heart a long-needed rest after 36 years. September, I was back cycling with my friends, but foolishly took myself off the beta blocker for 2 days and put myself back on an older medication, a calcium channel blocker, which I'd used before. I felt better on this because it did not suppress my heart rate as much. I was feeling good finally and got involved in a little sprint with the group. Within 15 seconds after that, I knew I was in trouble again. My heart rate did not drop as it should. I kept looking at my heart rate monitor, not believing what I was seeing. Back to cardiology in the AFib clinic the next day with recurrent A flutter. Another cardioversion within 2 weeks, late September, with a comment from the attending cardiologist, Dr. Halperin, that perhaps I should consider giving up competitive sports. and that the EP people had done the best they could. He may not remember telling me that. I had already come to this conclusion after 6 months of not competing. Back on beta blockers and further ECGs, echocardiograms, and Holter monitors. Another visit with Dr. Lane, the EP specialist from Victoria, in early December. Advised me I should try and push it a bit on my workouts and that I had the option of one more ablation should the medication stop working or I develop nasty side effects. No guarantee of success because of the location of the area that is notoriously difficult to ablate. Last visit to AFib clinic in early February, told to maintain as is. Current status, have been training as much as ever on the skis and bike, back in normal sinus rhythm for the past 6 months now. But with my lowered heart rate, the training always seems more fatiguing than it should be, despite being in normal sinus rhythm. Have given up the idea of competing while on beta blockers, as I would simply not be competitive and get really discouraged. I would love to ditch the medications and become a competitor again, but I realize this may be in the cards. I will keep trying until I've exhausted all my possibilities. In retrospect, 2 things that I've learned from this 7-year journey. I was really naive in the beginning. If you are diagnosed with a persistent atrial fibrillation, the treatment is not easy, straightforward, and uncertain. There are no guarantees and always a potential for recurrence. You will often require multiple procedures to try and effect a cure. It will have a significant impact on your lifestyle, both mentally and physically, and more so even if you're a competitive athlete. It has been a real roller coaster ride for me, believe it or not. That's the end.
Thank you, Gerry and Kathy and Frank. We're going to take a short break. There are some refreshments at the back, and I see people jotting down questions. I have a bunch of questions too for our panel when we return. So get those questions down. We'll just go around the room, and you can just put your hand up, and we'll try to get through everybody. This break will be, I think, about 10 minutes. So I'll do a song and dance when we're ready to get going again. Thanks very much. And here. Before we do, a couple of things that I neglected to mention. First of all, a thank you to the nursing program at UBC and the Institute for Healthy Living and Chronic Disease Prevention, because they are I do a lot of these kinds of events, and these people are so well organized. And so a big hand to the organizers. And also, I forgot to plug my show, which is a no-no. So I do the radio show on CBC in the mornings from 5:30 to 8:30 a.m. at 88.9 FM. Please listen if you don't already. Now, I have all sorts of questions for our panelists, and I'm going to just ask a couple of them just to get us underway. There is a roving microphone, so just put your hand up and we'll get the mic to you as soon as we can. This is a question that I asked when I was in the line with somebody. We were talking about AFib, and I asked if you can feel it in your chest. Everybody's saying shortness of breath, but I'm just curious if you can tell that you have it when, and the answer is.
Not one bit when I first had it. They
Really?
asked me, I didn't feel anything. After the treatment, when I had the ablations and when I was healing, I could feel the fluttering and this sort of thing. But no, I got up in the morning, the only thing I knew, I was feeling my pulse in the heart rate monitor. But I had absolutely no strange feelings in my chest. And that's a question they kept asking me after. I said, no, I don't have that. And I had the persistent, maybe Dr. Halperin should tell you, there's 2 major types of AFib. And the persistent one is the one that I had, and it's the least common and most difficult to treat, and especially in athletes. And I don't know if Dr. Halperin somebody mentioned this, but any study you read nowadays, I've read a lot of retrospective studies of cross-country skiers and athletes, and they show the incidence is approximately 6 times the normal population. in athletes, the incidence of atrial fibrillation. And I had a fellow from Spokane just email me recently, a doctor in Spokane who's a very high-level athlete too, and he said, Gerry, I just read my Journal of American Medical Association. Since 1990, there's been over 300% increase in the diagnosis of atrial fibrillation in the USA. And any sports like Dr. Lane and Victoria, they'll tell you that a lot of their patients are athletes, and they're the most difficult ones to treat, as Dr. Halperin will tell you. And Dr. Lane explained to me that the reason that he had such a tough time with me is because you have an athletic heart, and the left ventricle is enlarged, and it's very muscular. And when they do their ablation lines, he said it's really hard to get down. He said sometimes you have to go at it 3 or 4 times. And he said that that's the reason why. But as far as feeling anything, no.
Okay, I want to ask one more question, and then I'll get to the audience, because there's some definitions and some terms you're throwing about that I don't understand, and maybe you can help me with this. Everybody's talking about cardioversions, is that right? So I need to know what that is, just so we all have a baseline of understanding, and an ablation. I have no idea what that is. So perhaps you could just explain those 2 terms for us.
I'll go for it. Okay, so a couple things. So atrial fibrillation we talked about is a journey. So it's something that not just something one has and doesn't have, one has over a long course of a lifetime. So atrial fibrillation can come, and as Gerry's told you, it can go. Okay, and so that would be an intermittent or paroxysmal is the term that we use, atrial fibrillation. There's other atrial fibrillation, and this usually happens later in the course, so usually it would come and go, perhaps come and go, and then it comes and stays, okay? And we call this persistent atrial fibrillation. And that atrial fibrillation, sometimes we can encourage it to go away. One of the ways we encourage it to go away is with a procedure called cardioversion. And what we do for that, and this is something we do every day, and I did this earlier on today to a patient, is they come to the hospital, they get a very short anesthetic, so they go to sleep, and then we give their heart a short little electric shock. And what this does is it allows, it wipes out the atrial fibrillation and allows the normal heart rhythm to come back up, okay? So that's one of the ways that we treat the atrial fibrillation that is persistent. Sometimes even all those types of treatments don't work, and then one comes into what we call permanent atrial fibrillation, meaning you're in atrial fibrillation all the time. So you're in that rhythm, we tend to control the rate, and then patients have the atrial fibrillation with the rate controlled. So we go from sort of normal rhythm with little spikes of AFib, then to more persistent, which we help to sometimes put back into normal rhythm, and then the permanent is sort of the natural history of what happens in atrial fibrillation. So we try techniques to try and move people sort of back along that spectrum, because in general, most people want to be the way they were when they were born, the way we are naturally in normal sinus rhythm. So ablation is one of the techniques that we use to try and help people stay in normal rhythm. So ablation is a word kind of like surgery. So, you know, some people say I had surgery. Sometimes that means little cut on take a little something off the back of your hand. Sometimes it's something much more major. And the same with ablation. Sometimes they can be little minor procedures, sometimes much more major procedures. But in general, what ends up happening is we enter the bloodstream, usually through the leg. We'll go up with a long, thin tube, which we call a catheter, and we bring that tube up to the heart, and we find where the atrial fibrillation is coming from. And with this, or the atrial flutter, depending on what the exact rhythm that it is, and we will go in and we'll actually put a small little burn, just like you would do in cautery, like in surgery. And that does, and we sometimes use it, it can be electrically. Sometimes we actually burn the heart with freezing and actually make a cold burn. And the bottom line is what we do is we create scars, and that scars helps to prevent the atrial fibrillation or atrial flutter from coming back. So that's what ablation is. And cardioversion, again, is the shock treatment that we do to restore normal rhythm.
Thank you. It's amazing that you can do that. That's
You know what? It is totally amazing.
So let's go to the audience. Here we go. There's a microphone for you right there.
Oh, thank you. Yes, I was diagnosed.
Here, tell you what. I'll take the mic, or you can take the mic back, and I'll just hold it like this.
I was diagnosed in June of last year but I'm in permanent AFib, and I had my first cardioversion last week. I had my first cardioversion last week, and it lasted 1 day. I have another one scheduled in April. The medication is not doing anything. I'm in very high AFib, and before all of this, I was very active and exercised a lot, and of course now I can't because my heart rate gets too high. What's the success rate for multiple cardioversions, I guess I would ask?
Did everybody hear the question? Okay.
Okay, I guess this is for me. So the heart is just like a person. We all have habits, and when you've got a bad habit that you just started, it's easy to break that habit. If it is something that you've done for years and years and years, that habit gets to be very difficult to break. So atrial fibrillation, if it's something that just occurred very recently, our success rate with doing procedures like cardioversion is very high, better than 9 times out of 10. The longer that you've had atrial fibrillation, the lower the chance of success. So while it might be successful for a few days, just like Gerry was talking about, it's more likely that the atrial fibrillation will come back, because what happens is over time, atrial fibrillation sort of begets atrial fibrillation. There are changes that actually happen within the structure of the wall of the heart in the atrium, and it actually leads to more arrhythmias. So the answer to your question is hard to say. We certainly know that if you failed once, your chances of failing a second time are a little bit higher, but that doesn't mean we don't have other options. We have medications sometimes, and as Gerry's told you, we have ablation and other things to offer people.
Thanks very much. We'll try the microphone again for some. Oh, you're close to me, so I'll just give it to you. If you just keep it pointed that way.
Doctor, you mentioned the symptoms of dizziness, lightheadedness, balance, and stuff like that in regards to this condition. Does it affect your blood pressure?
The answer is, so the question is, does this affect your blood pressure? A little bit, yes, and a little bit the blood pressure affects it. So we haven't really talked a lot about why you get atrial fibrillation. And usually the most common reason one gets atrial fibrillation is because the atrium gets larger. Okay, so it gets thicker and bigger. So there are a number of reasons for it. Gerry gave us one good reason. If you tend to be an ultra athlete, then the whole heart and the atrium as part of the heart tends to get bigger, and that's why that one group of people tend to get more atrial fibrillation. The more common cause is for when people who have other health issues, particularly high blood pressure. What happens is the heart muscle, as a result of that, since the heart makes blood pressure, so it has to lift more. It's just like going to the gym, the heart muscle thickens up. And when the heart muscle is thicker, if you kind of think about the difference between a ballerina and Arnold Schwarzenegger, you know, ballerina can be nice, thin, flexible, right? And it's easy for the heart to dilate when the blood comes into it. If it's thickened, like Arnold Schwarzenegger is walking around like this, it stiffens and it causes more back pressure. That back pressure stretches out the atrium and makes you have more atrial fibrillation. So the high blood pressure is one of the most common causes that sets you up for having atrial fibrillation.
What about perfect blood pressure?
Perfect blood pressure is a good thing to have, but it's not. Atrial fibrillation is not all one thing. So high blood pressure is certainly one of the roles, but it's not everything. There's certainly other things that can certainly play a role. Gerry gives you a fine example. He never mentioned his blood pressure, but I doubt very much that Gerry's problem was high blood pressure that got him into this.
Okay, next question. At the back there.
I think this is a question for Kathy. Is there any research that shows that if you have like young children and that you start them on a really vigorous athletic program when they're young, that with their developing heart, that it makes any difference in the long run? Like I know athletes, like I don't know when Gerry started, but you know, does it make a difference whether you start in your 20s or start when you're 10? Or
Actually, I think I'll pass this to Anne because I think she'd better answer that.
Yeah, I don't think there's been any research on the youth yet, but that is a very good question, and that is something that we'll likely be studying in the future. But when they did the studies on the athletes and the cross-country skiers in Sweden and Norway, as Gerry said, it was a retrospective study. So these people had, reaching more middle age, they were recalling back on how much exercise they were doing in their 30s. And the amount and the dose sort of exercise that they did in their 30s is really what increased their risk for developing atrial fib more when they were in their 60s. So it's not something that an athlete in their 30s is going to get it then. It's that they may increase their risk once they do get to that older age, getting up into their 60s and 65. And that is one of the biggest risk factors of atrial fibrillation is age. And that's a kind of a way of saying we're not really quite sure why. But blood pressure is one of them, and certainly weight's another one. And another one we haven't talked about is sleep apnea as well, has been associated with a higher incidence. So these are all the things that we direct a treatment to and correct those things, and try to manage it that way.
Thank you very much. Question in the middle here.
Is there a familial component, genetic or heritage?
Good question.
Absolutely. So like most conditions, there are some conditions you get from depending on your lifestyle and things, and there is certainly a genetic component. The genetic component gets to be a little bit tricky because if you look how we behave, I tend to behave a lot the way my father behaves. I tend to behave, other people in my family behave. So some of it is actually a lifestyle thing that goes from generation to generation, but there is no doubt there is also a genetic component, and we've certainly seen that with atrial fibrillation.
At the back.
General question. Can you connect the issue of sleep apnea with atrial fibrillation in terms of effectiveness or risk factors?
Just to expand on the connection between sleep apnea and AFib.
Okay, sure. So, So just along those lines, sleep apnea is one of the bigger risk factors for atrial fibrillation, and it's a tricky one because it's not one that we often think about. So we do know that patients who do have sleep apnea, it puts a lot of stress and strain on their body. We've already, Kathy's talked to you about some of the stressors that you know of when you're awake. This having sort of sleep apnea is the equivalent for people who don't know this. This is like choking yourself at night. So when we relax and we sleep at night, the weight of our throat can actually press and close off our airway, and it makes it difficult to breathe. So this is like being choked all night long, and that you can imagine what that does to your hormone levels, your stressor levels, and as well what it does to your blood pressure. So certainly undiagnosed sleep apnea is a big player in terms of atrial fibrillation, and controlling that actually can help reduce the amount of atrial fibrillation that you have and how you feel with it. I would like to take this moment just to stress, we talk a lot about how the doctors can send you for things and treatments for this. This is actually really one of those conditions that you can do an awful lot of good yourself without the help of a doctor or without the help of a prescription. Ann's talked to you about a lot of these things. Weight loss in general tends to be unbelievably helpful in this condition. It's not an easy thing by any stretch, and she said 10%, not so hard. I'll be honest, I think 10% is a little hard. But it's unbelievably important. People feel so much better with this. It's as effective as ablation, as effective as our medications in terms of making people feel better with atrial fib. And not only does it just make people feel better, when we do the objective quantitative tests, so we say how much atrial fibrillation you have, if you do these types of changes, we see less atrial fib. Not just how you feel, but you actually see less, and we see the heart actually structurally change and go back more towards normal. So this is one of the things where you can actually make big changes yourself in your lifestyle that can have a very positive effect on this condition.
Okay, thank you. Way in the back corner there.
Hi. I just want to, it seems like it's related to what I had, and I have asthma and COPD, and then I got this AFib in December. So it sounds like sleep apnea is the same as, or it affects and would cause AFib, just like sleep apnea? I mean, what's the
What's the connection?
yeah? What's the connection?
Okay. So if we go back a little bit again of what causes atrial fibrillation, remember I said there is that stretch in the atrium, or the atrium become bigger. So usually people with lung disease, we have, the heart is really kind of two hearts stuck together. We simplify it. There's one heart, the right side of the heart, which takes the blood from the body and then pumps it up to the lungs, where the blood comes from the lungs and we pump it out to the body. For people with lung disease, it tends to be more of a right-sided issue, because what happens with it as the lungs become diseased, whether with asthma or COPD, it puts the pressure up in the lungs. And just like I said with the high blood pressure, that back pressure goes back up into the atrium and stretches them out. So that's why we have that connection there.
Thank you. The other back corner.
Thank you very much. Ladies and gentlemen, I would like to say credit to Anne and her program at Coach and the Kelowna Cardiac Exercise Society. If none of you have taken advantage of that, I heartily recommend you do. I have done it. It's just wonderful. My other question to the panel is an experience through my wife, and there'll be one other question to Chris too. Why would a medical professional, when my wife was suffering through AFib, tell her just to live with it? She said she was told that a lot of people just live with it. And the consequences of living with it forced her to have an ablation, which has done wonders for her. And then my last question to Chris is, I'm wondering why CBC did not send you to Washington to report back to us on our new Prime Minister's dinner tonight with his wife and so on. Thank you.
Okay, well, maybe I'll get that answer out of the way. I was invited, but I had to decline because here I am.
Okay, I'm going to answer your question, but before I just want to comment about the coach part of things. I couldn't agree more about coach. So as one of the hats I wear, I help manage the atrial fibrillation clinic. And when you do, we have this clinic, we look at strategic partners to help out patients with atrial fibrillation. And as I've talked to you how important this weight loss issue is, that's through diet and exercise. And so we actually have a linkage between the atrial fibrillation clinic at KGH and the coach program, because we know how important this is. And we have, I can't say enough about the benefit for coach is done to patients with atrial fibrillation and patients with all different types of heart disease as well. So we are so absolutely lucky and blessed in this town to have coach. So thank you, Anne. Okay.
Can I just add to that? Yeah, we really promote the exercise and getting a safe habit formed for everybody, and obviously very passionate about what we do there. But also we have a lot of really great programs in the community too for exercising. So, and there are a few people here tonight from the Y and from other programs that run great exercise programs, often tailored to an older adult. So just look around in your community, and coach is always there, but there's other things available as well. And just walking clubs and walking programs, there are lots of those around, and so that can give you great benefit too.
Okay. Right.
Hi, I just want to know, is coach a place we go to, or that's not clear to me? How do we join that?
I'll just explain a little bit about Coach. It's a cardiac rehab program. So it is a program where you go in person and we offer supervised exercise sessions. So it's really for the person that really isn't sure how much exercise. They may still have some symptoms, and we can help coach them through that and help establish that exercise. So we see them twice a week for about 8 weeks. As well, we have some educational programs, and it really is a program that's directed not just atrial fibrillation, but it's for the coronary artery disease, people that have had open heart surgery and stents and that kind of thing. So our education is tailored towards helping support people in changing the risk factors for heart disease. But with this coordination with the Atrial Fibrillation Clinic, we are seeing a lot more people coming through with this condition. Yes, you do need a referral. Some people will come up and sort of self-refer. They may have seen, had their neighbor or somebody go through it. And when that happens, we just make sure we go through the GP that get a referral from them. It's usually pretty easy to do as long as the person is stable and under medical care. We can usually see them and they have an appropriate, condition for the program, any heart condition. And if not, we can refer you on to other programs in the community too. And we can be reached. There's a website. It's www.coachkelowna.com. And I don't have any brochures here, unfortunately, but it is also in the phone book and under the Central Okanagan Association for Cardiac Health. So you can find it, give us a call, and go from there. Thanks.
Okay.
Thank you. Go ahead.
You haven't mentioned anything about pacemakers, and I was just wondering if that's a common way to treat AFib, and is that something that is quite common, is my main question.
So the question about pacemakers and atrial fibrillation. Patients with atrial fibrillation tend to have the disease of the conduction system of the heart. That's really what, as the atrium stretches, that's what gets damaged. The conduction system of the heart not only happens in the atrium, but it goes through that whole wiring system that I was talking about. And if we have issues that, which the system isn't working as well, we can actually have times when the heartbeat will go slower and slower and slower, and that can obviously cause issues. That's when pacemakers come in and help out. But as far as treatment in general, we do have some snazzy pacemakers that occasionally try to trick people out of these arrhythmias and things. But for the most part, the pacemakers are used when patients have the need for their heart rate to keep from going too slow. Sometimes when we're looking after people with issues with their heart rates, all of our medications make the heart rates go slow. And there's a lot of intermittent issues. So sometimes your heart will go too fast and other times you go too slow. And we don't have smart enough treatments that just say, okay, now I'll go on, now I'll go off, now I'll go on. And so what we sometimes end up having to do is to sort of, if you would, put the heart rate into a sandwich where we use the medications to keep the heart rate from going too fast, and we use a pacemaker to keep it from going too slow and kind of just keep it in the sort of that happy Goldilocks zone. So it's not exactly a treatment for it, but it's certainly something that we often use.
Does it override the pacing of the SA node or the other nodes at high rate?
In general, so the question is, does it override your heart? These devices are absolutely incredible. They're very very sophisticated little computers in there. And so in general, we can control them quite well to do what we want. So we can have them function one way when you're in atrial fibrillation, other ways when you're not. But in general, we try to follow the heart's own natural rhythm and try to make them be used as little as possible, so long as it remains safe for you.
Thank you very much. Right behind you there.
I had a question about the AFib clinic. So what does it consist of and who gets referred there? Like, I guess it's based from the hospital, right?
Okay, so the atrial fibrillation clinic is something we've kind of grown over the course of about 5 years. The atrial fibrillation clinic works out of the RACE clinic, which is a rapid access clinic in the hospital. And people who tend to get referred there have to be referred in either through their general practitioners, or they quite typically get referred in from the emergency department. And who works there? There'll be a cardiologist who works there, either myself or one of my colleagues. And then we're lucky enough to have 2 atrial fibrillation nurse practitioners. So that these are nurses that are particularly trained in atrial fibrillation, and they're excellent resource. They're very knowledgeable on about all aspects of atrial fibrillation, and we work together to make sure that patients get the right treatment. So it's physically inside the hospital. You need a referral, and usually through a GP or emerge doc. Okay.
Thank you very much. We have another question. I have questions if no one else does. Oh, we do. We right here. Good.
I wondered if the electrical magnifying radiation is steady pulsing is a habit for the pacemakers and is creating a lot of the breakdown of DNA that's causing the AF. Like you said, it's on the rise.
Yep. Sorry. So the issue of atrial fibrillation being more common, why is that the case?
Well, I think a lot of it, we're constantly electrical shock. These smart meters
Yeah. Okay. I'm not sure about the smart meters and the cell towers. That's another issue altogether. But I do think that there's actually some good news in terms of why we have more atrial fibrillation. There's a couple reasons why I think we have a lot around here. People in BC are, we have one of the, we're blessed to have a population that's getting older and older and older. And as we've heard, this is a condition that certainly goes up as we get older. So again, very uncommon, but we certainly see it in people in their 20s and their 30s. But kind of as we get older, this is something we see more of. So it's sort of it's kind of a good news thing on the one hand that we're all living longer, but it's something, one of the burdens that goes along with it. I don't think really the radiation and cell towers is really a major player here in terms of that.
Go ahead.
Can you always know that you're having the episodes, or can you have them and not know?
So I think that we started this question a little bit and didn't completely answer it at the beginning. The symptoms associated with atrial fibrillation are a total spectrum. So Gerry's giving you a little bit of his kind of perspective on it, and he's kind of partway along the spectrum in that he certainly knows when it's happening because he's no longer Ironman or the super ultra athlete that he usually is, and yet now he's just like a normal mortal person. Okay, so that's how he can tell he's in atrial fibrillation. Other people are very, some people actually don't feel it at all, have absolutely no sensation, and actually they may just show up at their doctor sometime and the doctor notices it. We actually get a fair number of referrals coming in because people go to the gym, they go on the treadmill or the bike and they put their hands on those heart rate sensors and they say the machine's broken, right? It's not flashing the way it's supposed to flash. And so we get referrals in from that. Fitbits are another type of thing. So now that everyone tends to be much more monitored, you're wearing your iWatch with this health monitor and it says things are up. Blood pressure monitors are also another way. So some people have absolutely no awareness, and other people are on the total other end of the spectrum where they notice the second they go in, they can tell you when they're in, they can tell you when they're out, and they're very sensitive to the palpitations. So it really, everyone is different. We're all on a spectrum, and that spectrum is important because if you look at it here, you hear how Gerry's treated. I know a number of you people here have atrial fibrillation. You'll say, well, I never got treated like Gerry. How come he got all that stuff and I didn't get any? What's the matter with me? And you heard a little bit here. I was told just to live with it. And a lot of that comes down to how much this is bothering you. Because if this is bothering you a lot and interfering with your quality of life a lot, going through very aggressive treatments, which Gerry really went through. So lots of cardioversions, lots of ablations, lots of procedures, every one of which carries with it a price tag of risk, right? And all of our medications do. It has to be worth it to you. So in other words, you have to be bothering you enough that it's worth to pay that risk price. If you're, I don't know what happened in your case, for example, but it's quite likely if it's not bothering you very much, it might not be worth going through all those types of things where there's risks involved to you, and it may actually be better something just to live with it, okay?
In the blue shirt over there, yeah.
Hello, and thank you for coming out this evening. I have AFib, and I hike, and I bike, and everything else, but I'd love to have an ablation done. But 2 years ago, I was 207th on the list, and this year I checked, I'm 204 on the list, so I'm thinking I'll probably die before it happens.
Well, at that rate, anyhow, it's the wait list for AF. So in terms of things, electrical issues, the docs who deal with this type of thing deal with two types of major arrhythmias: the kind that really kill people and the kind that really bother people. Okay, this is fortunately and unfortunately the kind that just bothers people and not the kind that kills people. So the kind that kills people, they get to rise to the top in the front of the list, and you can understand that. In terms of things, it shouldn't be that long of a wait, and I think there must be something unusual happening in your case, and we can certainly talk about it offline, but this is a procedure, unfortunately, that we don't have here in Kelowna. I do think, though, that it's something, we've had unbelievably positive things that have happened at the hospital in terms of cardiac care. We are all unbelievably lucky here with cardiac surgery, angioplasty, and the other cardiac services that we have available to us. I do think this advanced type of care for cardiac electrical treatments, it's one of the two things that we don't have at this point, and I'm really very optimistic that we're going to see this type of treatment here in the Valley within the next few years.
Now, I know we're all exercising regularly and eating well and losing weight and all of the rest of it, but I always like to ask the questions about what I do, which is the opposite. So, I want to ask about specifically, someone mentioned coffee, but let's throw everything else in there. So coffee, smoking, drinking, sugar, what are the things that you can ingest that either help or probably hinder this?
All of the above. Well, I think it's important to remember that it's very individualized, that everybody's going to have they may have a trigger, they may have no triggers. And if you're having intermittent atrial fibrillation, it's coming on sometimes and not other times. It's a good idea to look at your diet, look at what you're doing, and make any associations there and try to maybe change things up to see if it has any effect. But it's going to be very individual. Some people aren't affected by any of that and can do that. Certainly smoking is not a good thing to be doing for any of your cardiac health. For coronary artery disease particularly, but some of those other things, moderate intake of caffeine or alcohol may not have an effect on you, or it may. So Frank's wants to chime in here.
This is the anti-alcohol. I'm glad we're not in an alcohol serving establishment. This is one of the areas, certainly what Anna said in terms of general cardiac health for sure, but alcohol's a big thing in terms of atrial fib. So if you have atrial fib, drinking should be happy birthday, Merry Christmas, Happy New Year, that kind of thing. But really, you don't want to be drinking a lot, because there's actually the slang term holiday heart sort of corresponds to you went out for a night of binge drinking, and this is what you get as you're present in the morning along with a hangover. So really, alcohol in this is not something that we like to see together. In terms of the other things, certainly we want everybody to be well, healthy, and a lot of those things certainly aren't conducive with that. So.
Yes, in the middle here. The microphone's on its way.
About marijuana?
Oh yeah, I forgot that one. Sorry. I have a long list, believe me. But
I think I'm going to turn this over to Kathy in the stress part. I'm sure someone's studying this, and I'm sure if any of you people want to be volunteer for a research study, just leave your name at the front. I'm sorry, I don't know very much about the role of marijuana in terms of this.
There actually is a researcher at UBCO that's studying the effects of marijuana on different conditions, and he has an interest in cardiac as well. But those studies haven't been done because it hasn't been a substance that's legalized and easy to study. So I think we'll look forward to see what the effects are, but really I don't think we can say at this point.
So the question is about artificial sweeteners and
Who wants to answer that?
aspartame and things.
I think it kind of goes along with lifestyle, and I don't think there's any link that we know of with atrial fibrillation, but certainly for your health, the more sugar we eat, the less nutrients we're getting from other sources, and the more weight we gain, and that is not a good thing, and it certainly contributes to the obesity epidemic and the things that we're seeing, particularly in young people. So amount of sugar that you eat is very important, and our dietitian is always saying, don't drink your calories. That could go for alcohol too, but don't be drinking, all of those drinks, because they contain a lot of sugar and there are really no nutrients extra with them. You should be eating the fruit if it's fruit juice. So I don't know of any studies, I'm not sure whether you do, on sugar and atrial fibrillation. Yeah, I don't know, and the artificial and the chemicals in that, and I don't believe that has been recognized or studied as yet.
Just before we wrap, we'll give everyone up here a chance to just sort of sum up their thoughts in a moment. But my last question, I always like to ask what the emerging, mind-blowing research is that is right at the cutting edge. Who wants to tackle that?
I'll go for it. I'll tell you. So I'll give you the words of a guru. So there's some. It's interesting. So one of the guys who actually has atrial fibrillation, he's one of the people who does the ablation. And when he talked about what was the most important study he saw in atrial fibrillation, it was actually the study that Anne referred to. So this is the study of that you can take control of your life and your symptom and your condition here. Now, it doesn't work for everybody, and you have to take this with a grain of salt, but really this issue of weight loss and regular exercise and that sweet spot, that Goldilocks zone, a little bit not quite being a Gerry, but you don't want to be a blob on the thing either, but I'm not going but really being thin and exercising to a moderate degree will make you better in so many different ways. Atrial fibrillation is just one part, but that's really, if I say there's one, getting now to your thing at the end, that's one most important thing that you can do in terms of helping yourself with this condition.
Why don't we pass the mic down to Gerry, and Gerry, if you could just give us a couple last thoughts, and then we'll move our way back here.
Well, I guess one thing that it's a question of, can you live with it? And the fellow down there asked the question. And I couldn't live with it because I had an athletic lifestyle and I've been doing sports for 35 years. But the first time I saw the cardiologist was in 2009. The first thing he said to me, he said, and he was an athlete himself. I had actually competed with him, or I'd competed with him. He's a lot younger than me, way back in the 80s in Kelowna. And he said to me, I think that you might want to dial it down a bit. And I said, well, I don't want to dial. I said, I'm competitive. I said, what would you do? And he said, I was talking about going through ablation and the medication and everything, he said, I would try the medication first and see if that works. And and I said, well, what about the ablation? He said, no, he said, I think you should handle this conservatively. And I said, yeah, but that's fine for somebody who's sedentary. It doesn't bother them. Like I was talking to Mr. Hicks here just a little while ago, who just recently diagnosed. He says it doesn't bother him at all. And I said, no, that's true. You go to a nursing home and probably 50% of the people in there have AFib. They're not aware they even have it. But for me, it made a big difference. For a lot of people, they can live with it. Like Frank said, he said that you can just live with it. But and if it doesn't bother you, it only bothers me when I start exercising at more than an easy pace. And that's what I like to do. And the other thing is too, the other big effect it's had on my life, and my wife is aware of this, is that since I've had this, I've had to cancel 6 trips, planned trips overseas. 2 of them were cycling trips I wanted to do in Spain, following the Tour of Spain, and 3 of them were World Masters cross-country ski races, and one was just recently in Finland. I had to cancel in November because of the uncertainty dealing with this. So to me, that's the biggest, the uncertainty. That's, for me, the uncertainty. You don't know whether you're going to wake up next morning and be an AFib. And it does create a lot of anxiety, hidden anxiety. And that's one of the questions they ask me. Every time I go to the AFib clinic, there's a questionnaire I have to fill out. The AFib nurse gives to me. And one of the questions they ask you is, are you concerned that this is going to come back again? 1 to 5, rate it 1 to 5. Very concerned or whatever. And I always say I'm concerned. I don't put very concerned, but I'm concerned because I've had this for 7 years and I've had 5 episodes, and 3 of those episodes have happened in my sleep, not when I'm exercising. And I've talked to there's a world-class masters athlete that lives in Vernon, who a lot of you are aware of, and he has paroxysmal atrial fibrillation. And I know this fellow quite well because I've traveled with him. And I said, does it ever bother you when you're out? Because he's done a lot. He says, no. He says, Gerry, I wake up with it in the morning. I've had it 4 or 5 times. And I said, what do you do? He says, I have a standing order for cardioversion at the Vernon Jubilee Hospital. And, so it's the uncertainty of dealing with it, and that it could come back again, and it has really affected my ability to want to travel and compete, in that I've had to cancel a lot of events. And that's probably the biggest effect it's had on my life. So it hasn't been smooth sailing, and even though but I live with it and I'm getting better at living with it, mentally.
Anne, go ahead.
Well, I think you've really hit the nail on the head. It's frustrating. It's a frustrating condition, and it's really the not knowing and that uncertainty. And we're left with just managing the symptoms and making sure you're under the care that you need to be, and then finding those things that you can do that give you pleasure and that help things along. And that's certainly where I support anybody in their venture doing that. And that's where our program kind of has come in to help with that. But I think there's a lot of research that's going to be going on. This is an emerging problem. I mean, it's been around for a long time, but it seems that it's very topical. More and more people have atrial fibrillation, so we'll likely in the future see more and more of the studies going on and answer some of the questions that you've had that we haven't been able to answer tonight. Kathy?
And I guess I would say that certainly with a lot of the patients that we talk to, and Gerry's journey has been an up and down journey, like a roller coaster, like he said. Oftentimes, some of the many patients find that certainly the beginning months and year after a diagnosis are particularly stressful, but they oftentimes do find themselves, getting into a way or a way of dealing with it, and so they find it much easier as time goes along. Oftentimes, I say Gerry's experience has not been like that, but I do think that everyone does need to sort of work with their providers. There's much that they can do on their own, but also a lot of caring for your atrial fibrillation. I think is a team effort with you, with you and the care providers trying to set goals that you want, and they can help with the treatment. There's lots that you can do in terms of just like you said, like lifestyle management, stress management, and those types of things. So I would just kind of encourage people that it seems to get better for most people as they go along in that journey.
Okay, so I get the last word, which is quite lucky. And actually, that's the word I'm going to, I honestly consider myself, and I think we all here are unbelievably lucky. We're at a time when we have all sorts of options that are available. We are lucky that we live where we are in a beautiful part of the world. We're lucky that we have the services that we have available from what Anne and Coach, what we've been lucky enough to have at the Atrial Fibrillation Clinic. And we're lucky that we all have options in the things that we can do, things that we can change in the life ourselves. And I would like to encourage you to take advantage of those, sort of that luck, if you will. This is as Kathy said, this is a team effort. It's a long-term journey, and it's one that works best when we work together. So no one likes pills, no one likes procedures, all of those things. But I mean, it is something that if one keeps an open mind, does the things that they can do to help, works well with the provider, atrial fibrillation is something you can live with. Sure, it can have a significant impact in terms of your life, but it's something you can live with, and you can live for a very long time with it and have a very good quality of life and a very good length of life. So I would like to encourage you to make sure that you all, if you have atrial fibrillation, you talk to your doctor and other healthcare providers and work together with them so that you can take advantage of all the fantastic research that's been done, the new treatments that we have available, so that you get the most benefit for yourself.
Thank you very much. Just a reminder before we go that the surveys that are on your table. Thank you all very much for coming, and I hope you'll join me in thanking our panel. And thank you to UBC for inviting me. I appreciate it.